Good afternoon. My name is Ian Smithson. I'm an orthopedic surgeon at OrthoVirginia with fellowship training in surgery of the shoulder, elbow, wrist, and hand. I'm talking to you today from our office in Lynchburg, Virginia. And today we're going to talk about kind of a newer treatment for irreparable rotator cuff tears that is a little less common, but is becoming a useful tool in the armamentarium for orthopedic shoulder surgeons. So the shoulder, everybody has one. Most of ours don't look like this, guys, but the shoulder is really important for helping us put our hand where we want it to go. So there are all sorts of different types of shoulder pathology that you may or may not have heard about. Rotator cuff tendonitis, some people call that bursitis. There are rotator cuff tears, there's impingement syndrome, biceps tendonitis, AC joint arthritis or arthropathy. There can be labral tears, there can be arthritis, there can be instability. But today specifically, we're going to talk about rotator cuff tears, and really the more challenging rotator cuff tears, which are rotator cuff tears in people who don't really have something that we can just put back together. So here's an example of what the rotator cuff is supposed to look like on the left-hand side of your screen. The rotator cuff is made up of 4 muscles and 4 tendons. They basically are there to hold the humeral head down into its very vertical, otherwise unstable socket, and to initiate motion in the first effectively 45 degrees in every direction. On the right hand is an example of a rotator cuff tear, where that tendon has torn off of the bone or just before the tendon attaches to the bone. And that's basically what a rotator cuff tear is. And that can lead to pain or weakness, or even a combination of both. So what causes a rotator cuff tear? People talk about rotator cuff tears in the general population all the time, but it can be the result of trauma, such as dislocating your shoulder can result in a rotator cuff tear. It can be a repetitive overuse injury. It can be the result of chronic shoulder instability. It can just be a wear and tear phenomenon. There's also a little bit of genetics in it. Not many of us can wander far away from our parents' genetics. And so if our parents had rotator cuff tears without having big trauma, the likelihood is that we're probably in line to have some sort of that pathology as well. All right, so this is a pair of pictures that comes from the Academy of Orthopedic Surgeons. On the left is a normal rotator cuff tendon coming down in the shoulder. We're looking at the inside of the shoulder. You can see that there's a big white ball that kind of looks like a cue ball that's labeled the humeral head. And that tissue that's coming from the top of the screen down, inserting onto that humeral head, are 2 of the rotator cuff tendons, called the supraspinatus and the infraspinatus. On the right side of the screen, you can see that same humeral head where there's a big giant hole in that rotator cuff tendon. And that leads to dysfunction of that rotator cuff. Again, that can lead to pain, weakness, or both. Now, I want to step back for a second because we're talking about irreparable rotator cuff tears, but does everybody who has a rotator cuff tear need to be fixed? No. There are all sorts of people running around on the face of the planet who have no pain, who have no weakness, and they may have a small partial thickness, they may have a small full thickness. Some people can even have a full thickness tear and have no pain and relatively no dysfunction. And in that setting, those people don't need to have any kind of surgery. However, in patients who do have pain, in patients who do have weakness, who do have a rotator cuff tear, we try and fix those. So how do we fix them? There are multiple techniques that have been developed over the course of time. Procedures are done either open or arthroscopically. More and more, I think people are leaning towards arthroscopic repairs, where we use tiny little incisions and a camera and then little arthroscopic tools in order to place small anchors in the bone. And then we repair the torn tendon back down to the bone. Now, this isn't carpentry. This is more like farming. What we're trying to do is we're trying to induce the body to heal that tendinous tissue back down to the bone. And so after your surgery, most people end up in some sort of immobilization for 6 or more weeks so that that rotator cuff tissue heals back down to the bone. So here's an example on the left-hand side of the screen. Again, this is from the Academy of Orthopedic Surgeons, of a hole in the rotator cuff. You can see that bright white humeral head in the middle and that kind of beaten up tissue surrounding that hole. The picture to the right shows that tissue that's been brought back down to its native footprint and having been repaired down with suture material. That suture material comes out of these little bone anchors that are placed inside the humeral head and then hold that rotator cuff tissue back down to the bone. But again, this relies on a lot of things. Number one, you have to have good enough tissue to bring back down to the bone. Number two, that tissue has to be strong enough so that our suture material can actually hold on to or grab it. And then it relies on the body's ability to heal that tissue back down to the bone. But what happens if you don't have good tissue? What happens if that tissue is so contracted that it's not able to be brought back down to the bone? That leaves us with a problem in terms of trying to get an individual's function back to where they want to be. The frustrating shoulders for patients and for providers are those patients who have recurrent rotator cuff tears, people who have poor quality of their rotator cuff tissue, or they just have an irreparable rotator cuff tear. So what options do we have for these? We can debride those painful tissues through a scope or in an open manner. We can do something that was developed about a little over a decade ago called a superior capsular reconstruction, which effectively provides a bumper between the top of the ball or the humeral head and the underside of that little bone that we can all feel on the top of our shoulder called the acromion. That's had variably good outcomes. There's something that's been out for a few years called a tuberoplasty, which also, similar to the superior capsular reconstruction, creates a bumper between the ball and that acromion. There's something called a reverse shoulder replacement. And then the final option is something called the tendon transfer. Tendon transfers are really beneficial for those patients who are too functionally active and too young for a reverse shoulder replacement. Reverse shoulder replacement came on the market about 20 years ago in the US, about 30 years more years ago in Europe, and they were developed for patients who had really poor functioning rotator cuff pathology. And they've worked really, really well. And they continue to be one of the biggest and most powerful tools the shoulder surgeon has in his or her armamentarium for restoring patient function. However, they carry with them some restrictions, like a 30-pound weight limit on the operative extremity for life. They are a joint replacement, so they're not your tissue, and they have some restrictions so that you don't dislocate your shoulder. Just like with any other joint replacement, over time they can wear out. And so where we as shoulder surgeons have been looking for help has been in those patients who are young, who have irreparable cuff tears, and who need to be really highly functional. Think of somebody who needs to swing a hammer for a living, somebody who still has to carry their kids or grandkids, somebody who's very active and needs to be able to do more than what that 30-pound weight limit with the reverse shoulder replacement require of them. So I'm a big fan of Wikipedia. I'm also a big fan of Dr. Google. So I thought I would just go ahead and go to my go-to here. So according to Wikipedia, a tendon transfer is a surgical technique in which the insertion of a muscle is moved to a new insertion point in order to restore a lost function. I don't know what that means. Do you know what that means? Let's go to the next slide. Exactly. That's exactly how I feel. And that's how I looked most of the time when I was in medical school too. They were talking about stuff like this. Bottom line is, muscles move bones. A muscle has to cross a joint in order to move that joint. We were incredibly designed. And in a lot of ways, we were over-engineered. Hand surgeons, thanks to Paul Brand and other surgeons in his time more than 70 years ago now, realized that in patients who had nerve problems, traumatic injuries, muscle problems, that we could borrow some muscle tendon units and move that tendon just a little bit to restore function where that function had been lost. And in doing so, we can restore function that's been lost. And this is a pretty incredible tool. So it definitely sounds scarier than it is. This is something that, again, has been done in the hand, in the forearm, and the foot for really more than 70, 75 years. It's also been done a lot in pediatric brachial plexus injuries, which is a topic for an entirely different day. But the point being, in the world of orthopedics, it's very, very common. In the world of shoulder surgery in adults, it's a little less common, but is taking off rapidly because patients are doing so well. So who's it for? It's for people who have recurrent rotator cuff tears or muscles that don't really work for multiple reasons. It can be from nerve compression. It can be from previous infection. It's for any rotator cuff pathology that results in the loss of function. Again, pain or weakness in people who don't have repairable tissues. All right, who can have it? If you have really bad arthritis, a tendon transfer is probably not in your best interest, but actually that's only mostly true, and that's yet a topic for another day. If you have an active infection, you also can't have a tendon transfer because we don't want to make you worse. And then any patient who is unable or unwilling, that was to my brother there, unwilling to follow their post-operative restrictions. All right, so what are our options? So this is a really technical slide, but basically there are 2 or 3 muscle tendon units that we use to restore function that's lost in the rotator cuff that does not result in dysfunction for the rest of the shoulder. So if you want to come back to this slide and rewatch this, that's great. If you want specific questions about that, come back to that too. I'm basically going to talk to you about the 2 workhorses for restoring rotator cuff function in tendon transfers. The first one is the Latissimus dorsi. Here's a picture of on the screen of the back of a person, and that bright red muscle is the Latissimus dorsi. It's that super sexy muscle that people who are doing lat pull downs and pull-ups are trying to make. If you zoom in and look at the picture of the humerus, which is the bone in the middle of the screen, there's something that says LD on it. That is the insertion of the Latissimus dorsi. It is a very powerful internal rotator. The nice thing about the Latissimus dorsi is we have a lot of internal rotators for the shoulder. That's bringing the arm in like this, but we only have 3 external rotators, and those are our rotator cuff muscles. And so if you've torn all of those, you can have strong internal rotation, but nothing to bring the arm out. And we can move the Latissimus dorsi to the outside of the arm to help recreate that. So it can help with, depending on where we place it, the Latissimus dorsi can be moved higher up if somebody has torn the big rotator cuff muscle in the front called the subscapularis, or it can just simply be moved to the outside of the humerus, and all of a sudden, magically, instead of being an internal rotator, it's an external rotator, and it's really easy to learn how to do that with physical therapy after your tendon transfer. This is just a study that was performed a couple of years ago. This is a retrospective study, meaning somebody looked back at 70 patients with latissimus transfers, all had an improvement in their shoulder scores, all had a decrease in their pain, all had an increase in their forward flexion and their external range of motion, which is what we're trying to get back with these irreparable rotator cuff tears. So this is probably the newest and the hottest topic in terms of tendon transfers. This is called the lower 1/3 trapezius transfer. This can be really, really useful in massive non-repairable rotator cuff tears. So tears of the supraspinatus, which is right on top, the infraspinatus, which is on top, but a little bit toward the back, and then the teres minor, which is all the way on the back side of the humerus. But this can be really powerful for restoring both external rotation and forward flexion. All right, so this is another outcome study. This is from the Journal of Shoulder Elbow, again, a couple of years ago. Looking back at 33 patients with the lower 1/3 trapezius transfers. Here's the age range, 31 to 66. If there's a 31-year-old who needs one of these, that person had a really bad cuff. And these patients all improved in their subjective shoulder value, which is a 0% to 100%. My shoulder is horrible. It's a 0%. I can't use it, to 100%. My shoulder is the best shoulder function I've had in my life. Dash score, which is basically function of their daily living. Shoulder range of motion, all had an increase in forward flexion and external range of motion. So this is pretty exciting. It means it's pretty powerful and useful. This is that bright red area is the lower third of the trapezius. This is, again, one of those superficial, sexy back muscles. And if you look, it's in the same line of pull as those other rotator cuff tendons, and it works really well as a tendon transfer. And the nice thing is, because it's already on the back and it's in perfect line with the rotator cuff muscles, there's virtually no education that needs to happen from a therapy standpoint. This is how we harvest it. This is an open portion of the procedure, and then the rest of the procedure is done arthroscopically. That tendon is lengthened using an allograft, which is a tissue that comes from another person who has donated it at their passing. This is a picture of where that tendon is going in the line of pull. And then this is how we do this arthroscopically assisted, bringing that tendon through and then inserting it using the scope with those same type of bone anchors that we do for primary arthroscopic rotator cuff surgery. All right, so here's a video of a gentleman who had this surgery, and he was 12 weeks out from his surgery. I'd be lying if I said that all of my patients doing this tendon transfer have that kind of function at 12 weeks. That was pretty incredible. Next gentleman, he is a year out from his tendon transfer, and you can see his range of motion. And then you'll see me coming in and trying to push down on his hand and getting him to resist me. And he's got good strength, no pain. And he was very pleased with his outcome. So, in summary, tendon transfers are a good option for restoring the function of rotator cuff tissue in the setting of irreparable tears. They're not for patients who have infection. They're not for patients who have bad arthritis and those who can't follow the post-operative therapy protocols. They are becoming more common as a tool in restoration of shoulder function. And one of the reasons I wanted to do this talk today is because it is becoming much more common around the country. And I just wanted people to be aware that this is coming and may provide a real benefit for those patients, again, who have irreparable rotator cuff tears, but aren't ready for a reverse shoulder arthroplasty. All right, I think that's it that I have for you. I think we're at the question and answer period.
Thank you so much. We do have some questions that have come in. We are going to answer questions that came in ahead of time and questions that came in while we've been talking. However, we will not be able to answer every single question. So, one question that we have is this for a current injury or for an older tear? When was the injury that caused the tear versus when you have the surgery?
That's a great question. It really doesn't matter from a time standpoint when the injury occurred. It really comes down to tissue quality. Oftentimes we can tell that on the MRI scan ahead of time, but not always. There are some times where in discussion with my patients, we'll talk about the plan to be to repair the cuff. However, if the rotator cuff tissue is not going to hold our anchors, then the plan preoperatively is to change and do a tendon transfer originally. But it's very useful in all settings, acute or chronic. I would always rather, in my own cuff as well, I would always rather have healthy tissue down to bone if I can, only using the tendon transfer as an alternative if I don't have that healthy tissue.
Thank you. How long does it take for the tendon to heal after the tendon transfer? And how much physical therapy is required?
That's a great question. And I'm going to answer it in two parts. So the first question, how long does it take for the tendon to heal down to the bone? The bench science tells us that it takes 6 to 8 weeks for tendon to bone healing to start. So that's why people are placed into a mobilizer or sling for 6 to 8 weeks to allow that biology to take place. But then that tendon to bone healing has to become oriented in a way that is meaningful and provides strength to the repair, which is why usually the first 6 to 8 weeks we're in a sling, and then the next 6 to 8 weeks we're working on gentle range of motion, and then we start strengthening after that. And in parallel to that, somebody asked another question about the tendon tissue that we use to extend some of our tendon repairs. Cadaveric tissue that is donated is treated in such a way where the cells that made up that tissue are gone. So there's no transmission of any kind of disease, nor can you have graft versus host type symptoms. But it's the matrix, it's the building blocks of that tendinous material that is what we use. And our bodies, when we receive that material, will actually slowly over time migrate new cells into that and then replace it and rebuild it and remodel it over time.
Thank you. Is there an age limit on having a tendon transfer?
No, I mean, the youngest person I have ever done one of those transfers on was in my fellowship, and that patient was 3 years old. And because they had a brachial plexus injury. And the oldest patient I've done a tendon transfer on was 92, and that was the result of a traumatic injury. There's no age limit, but it's, again, you have to match the treatment for the appropriate pathology.
Thank you. Might it tear again after a tendon transfer?
That's a great question. This is the same kind of question that my kid asked me after he broke his humerus. Daddy, I broke my arm and I had it fixed. Can it ever break again? Absolutely. If we do something silly, if we have another accident, it can break again. Tendon transfers are pretty robust. The tendon material that we use to extend the length of the tendons is primarily an Achilles tendon allograft. It's a very thick tissue. It's a very robust tissue. I have not personally had a tendon transfer fail, but it's certainly possible, and I will never say never.
Thank you. How significant does arthritis have to be a reason not to get a tendon transfer?
Oh, you're digging deep here. So we in orthopedics grade everything 1 through 4. I think it's because we're not very intelligent, and 4 is about as high as we can count without getting our thumbs involved. Grade 1 is just a little thinning of our cartilage. Grade 2 is thinning with some little kind of fibrous changes. Grade 3, you're starting to see some pretty significant softening of the cartilage. And grade 4 looks like a New Orleans street full of potholes riding over it with a flat tire. In grades 3 and 4, certainly in grade 4, doing a tendon transfer without doing something about those arthritic surfaces is going to result in a stiff, painful, not particularly functional shoulder. And so just having arthritis does not mean that you can't have a tendon transfer, but it means that you have to do something about that arthritis as well. Case in point, and again, for a talk on another day, in patients who have no external rotators left, who also have arthritis and need to undergo reverse shoulder replacement, we can also do, and commonly do perform, a latissimus dorsi tendon transfer to restore their external rotation. So it's the difference between, with just a shoulder replacement, being able to get the arm straight up in front, which is great if you're always facing what you're doing. But if you ever want to get your arm out to the side, the reverse shoulder replacement doesn't do that without the tendon transfer.
Thank you. If somebody has a second rotator cuff tear in the same shoulder, is a tendon transfer an option, or does it have to be a reverse shoulder replacement?
Again, it depends on the degree of arthritis. In grades 1, 2, and maybe 3, tendon transfer is a viable possibility with a long conversation with your surgeon. But if you have grade 4 arthritis and changes around the joint that are significant with end-stage arthritis, doing a tendon transfer without resurfacing that joint with a reverse shoulder replacement would be ill-advised.
Thank you. During a rotator cuff repair, could the rotator cuff be determined to be unrepairable and a tendon transfer started during the same surgery, or are they separate surgeries from the start and determined ahead of time?
In my practice, it's usually, I tend to have more of a revision-based practice. And so I'm having this conversation with my patients at the time planning for their initial surgery. You're looking at the MRI based on the exam, looking at their x-rays. I don't usually go into a rotator cuff surgery thinking I'm going to have to do a tendon transfer. But in those patients whose MRI is suggestive that of poor quality tissue that I may not be able to deliver back down to its native insertion, then we would talk about the possibility of doing a tendon transfer, and that would be part of the same surgery.
Thank you. Can you explain again the relationship between a reverse shoulder replacement and a tendon transfer? We have a few people asking if you can have a tendon transfer as part of a reverse shoulder replacement.
You can. The only reason to have a tendon transfer at the time of doing a reverse shoulder replacement is if before your shoulder replacement, you've completely lost your external rotation. And so let me show you what that means. So if I'm going to try and stay in the picture here. Actively, I can externally rotate my arms. But in patients who've lost all three of the rotator cuffs sort of in the back and the top, I may not be able to externally rotate my arm. And so if somebody pulls my arm out and then it slides back like this, that's called an external rotation lag sign. Doing a reverse shoulder replacement will help regain that forward flexion, but unless we do a tendon transfer at that point in time, they won't also be able to regain external rotation. And so sometimes we need to do a tendon transfer as part of a reverse shoulder replacement, but not usually. Usually the reverse shoulder replacement is a powerful enough tool that that's all we need to do.
Thank you. Do the tendon grafts always come from donated material, or do they sometimes come from elsewhere in your body?
So in ACL reconstruction, we can use hamstring autograft, which is tendon that comes from our body. We can use patella tendon autograft. We can use quadriceps tendon autograft. These grafts are not big enough for the tendon transfers in and around the shoulder. And so primarily for these tendon transfers, we use allograft, which is donated material. The other thing that's advantageous about using the allograft is it's an Achilles, primarily I use Achilles tendon allograft, which is a very big and thick tendon. Nobody wants to have their Achilles tendon taken as an autograft, meaning from themselves, because then it would be really hard to push off and walk. Nobody has made a synthetic version of this that is workable at this point in time.
Thank you so much, Dr. Smithson. That is all the time that we have for today. If you would like to make an appointment, please visit orthovirginia.com/appointments. Dr. Smithson, would you like to close?
Thank you guys so much for taking the time to view. This is something I'm obviously very passionate about, and I encourage you all to explore and read up about this if it's something that you think may be beneficial for you. Thanks and have a great day.